So we are going live in 3, 2, 1. So, Janki, you can start.
Are you starting or?
Yeah, we can start.
So, good evening, everybody. Welcome to this today's lecture, which is going to be done by Professor Hitesh Shah from Manipal. As you know, he's a pediatric orthopedic surgeon based in Manipal and has had a huge experience working there over the last many years. And it's always a pleasure to have him with us on our OREF programs. And today he's going to talk to us about osteotomies around the hip in children. I think this is an area where often there's a lot of confusion and people can't really decide which osteotomies is suitable for which particular child in what situation. So I think to clear all these doubts, we have Professor Shah today, and Hitesh is going to enlighten us about the osteotomies around the hip. So over to you, Hitesh.
Thank you. Good evening, Dr. John, for the kind words and introduction. Yeah, I will share my screen. Is it visible?
Yeah.
Yes.
You just need to make it full screen.
Yeah.
That's great. Okay, get going.
Is it full screen? It's visible?
It's visible now, so you can start.
Yeah, it's fine. Yeah, good evening, friends. So I'm going to talk on the osteotomy around the hip in children. As Dr. John said, it is one of the complex topic. Many of the postgraduates would be lost, and it will very commonly ask the question till it will be asked in a DNB and MS ortho exam. So it will be a full question. So what are the objectives of my talks? So I'm going to discuss how the osteotomy in children are different than in adults, because the previously used to perform the Bombelis osteotomy or valgus extension osteotomy or the McMurray's osteotomy for the neck femur. Why this topic is important? What are the various etiologies of the hip joint where the osteotomy of the proximal femur and acetabulum would be needed? Indication, whether it is the angular correction, whether it's displacement correction, whether the congruency of the joint, what is needed for that, the indication exact for doing the osteotomy. Then we'll discuss few points on the pelvic osteotomy. What are the various types of pelvic osteotomy? What are the various types of the proximal femoral osteotomy? And the principles of various osteotomy. How the principle of valgus correction is different than the varus correction. Coming to the first point, why the osteotomy in children would be different. There is always the fourth dimension, and we must understand when the orthopedic resident or the consultant know the 3 dimension, they must be aware about the 4th dimension that is very unique for the kids. That is the growth of the proximal femur and the growth of the acetabulum. Both are different in a child and then the adult. How it is different? When the child is born, the neck shaft angle would be around 160 degrees, and as it grows to the adult, it will reach to the 120 degrees. So it is impossible to predict what is actually the neck shaft angle, and different pathology will behave differently. So it would not be the identical for all the pathology. So that is the reason the osteotomy in kids is different. The second point, there is a growth of the acetabulum. The growth of the acetabulum would be also different in terms of the version and inclination. The femoral anteversion would be much more when the child would be born and reach to the adult level. Similarly, the acetabular dysplasia, when the child would be born, the inclination of acetabulum would be higher, and it grows up more than 1 year, it can reach to the 20 degree of the acetabular angle. So that's how it will be different than the kids. Similarly, when there is an anteversion, the femoral anteversion and a tibial anteversion, the acetabular anteversion, that also decreases along with the time. So if you see in a very young child, the femur and acetabular anteversion would be more, and as the child grows older or near maturity, it goes on. Another important aspect is the blood supply. The blood supply of the proximal femur would be different. It would be supplied by the end arteries, and that is the reason whenever we'll see the child between the 6 to 8 year of age, we may find out the complication is the avascular necrosis. So that we need to take into precaution. Another aspect, the proximal femoral deformity and hip dysplasia would be interrelated. How? If there is a proximal femoral deformity, it will affect the final shape of acetabulum, and vice versa is also true. The shape of the acetabulum can affect the shape of the proximal femur. These are the basic fundamental for understanding for the pediatric osteotomy around the hip joint. Now coming to the points, why the osteotomies will be required. Sometimes it will be preventing. Preventing osteotomy means we need to prevent the alteration in the size and shape like Perthes disease. The varus osteotomy is required for the containment of the hip. That is a preventing surgery. Correcting means alteration of the size and shape like acetabular dysplasia, correction in DDH, or the salvage surgery like the pelvic support osteotomy. I'm not going to talk on the salvage osteotomy today, but mostly concentrating on preventing and correcting surgery. The third question is that which condition will require to have the osteotomy? What are the various osteotomy in kids will require the correction in the proximal femur osteotomy? The commonest would be if you see about the congenital problem where it can have a commonest is the coxa-vara, where there is a what are the condition can lead to the coxa-vara, either the congenital coxa-vara like congenital short femur or a PFFD, or the developmental coxa-vara, or either would be post-septic sequelae or following a trauma, and there's a non-union or the malunion of the neck femur, or there will be tumor, osteofibrous dysplasia, osteogenesis imperfecta, or the Perthes disease. All this condition can lead to the varus deformity. As the child grows in adolescent condition, that may be the slip capital femoral apiphysis. But the identical things for all this condition may turn out with the coxa-vara. Compared to this condition, if you see about the coxa-valga, very commonly, the commonest disorder is the developmental dysplasia of the hip joint. In case of the paralysis like the cerebral palsy, poliomyelitis, the spina bifida, there would be the coxa-valga along with the subluxation or dislocation of the hip, post-septic sequelae, the avascular necrosis, or the lateral growth arrest, or the PFFD, or the skeletal dysplasia. Very important, I like to emphasize, we need not to concentrate on the various etiology, but whenever there would be coxa-valga, along with the femoral anteversion would be more, that can lead to the hip instability. And if there is a coxa-vara, that can lead to the limp and the lurch and the shortening. These are the very important understanding for the correction of the deformity along with the coxa-valga or a coxa-vara. I'm not going in detail for the specific terminology of the most of the osteotomy. We will talk in regards to the DDH or the commonest congenital pathology. So what are the types of the osteotomy? Either the pelvic osteotomy or the femur osteotomy. The commonest is that the pelvic osteotomy. And why the pelvic osteotomies would be done? That is very common to have the acetabular dysplasia. So many times the topic would be asked that treatment of the acetabular dysplasia. Sometimes it will be asked as the treatment of the hip dysplasia. Sometimes it will be asked as the different type of the pelvic osteotomy. So if it is asked as a different type of pelvic osteotomy, you need to concentrate on acetabular dysplasia and correction of acetabulum. It would be asked at the hip dysplasia, we need to say about the proximal femur and acetabulum. So we need to take about the osteotomy of the both side of the hip joint. For the acetabular dysplasia, for the person which is new or not knowing that what is the acetabular dysplasia, whenever the orientation or the dimension of the acetabulum which is such a way that the acetabular coverage is insufficient, that is called as the dysplastic acetabulum. I will repeat, whenever the orientation of the acetabulum is abnormal or the dimension, means the size of the acetabulum is abnormal. The size may be dysplastic in terms of the smaller acetabulum or the larger acetabulum. For the understanding of the acetabulum, when we say that what is the function of acetabulum, it will provide the adequate cover, it transmits the force across the hip joint, and it will ensure the stability of the hip joint. So it provides the adequate coverage for the femoral head. And it is, if you see the normal acetabulum, it is in the antevertebrate. So if you see from the front, the anterior part would not be covering the entire femoral head, while the posterior part, posterior head, would be going up to the 50 or a more than 80% of the femoral head. So the normal orientation of acetabulum is in normal anteversion. This is the basic understanding of the acetabulum. If you see about the normal shape of the acetabulum. So whenever we see about the acetabular dysplasia, the size may be smaller or large in relation to the femoral head. And when we see about orientation, orientation can be seen in a two dimension, either the version and the inclination. So when we see about the orientation, we see from the cross section of the femoral head, whether it is in anteversion or retroversion. When you see about this case is having the posterior head is posterior part of the acetabulum is covering more, so it will be in anteversion. So the femoral head lies it here. That is the anteversion. And if you see about the dimension, dimension can be seen the width and the depth. So if you width can be measured from the lateral margin of the inferiormost aspect of the teardrop to the lateralmost part of the acetabulum, that is to be measured from the width. That important aspect is only not about the width, but the depth of the acetabulum. If you see about the lateralmost part of the acetabulum to the teardrop and see about the central point and go to the depth of the acetabulum, and that is the normal acetabular depth. And if you see the acetabulum is the dysplastic, the depth will be reduced compared to the normal hip joint. So the acetabular dysplasia, when there is a dimensional dysplasia or a directional dysplasia, the depth of the acetabulum would be decreased, and that can lead to the uncoverage. So again, the orientation may be abnormal or the dimension may be abnormal. Dimension may be insufficient. So in other sense, whenever there is a direction, that direction in terms of the acetabular inclination would be more, that is called as the directional dysplasia, where the dimension of the femoral head and the acetabulum, means the size of the femoral head and the acetabulum is equal, but the direction is abnormal, that is called as the directional dysplasia, where the femoral head and acetabular size is equal. What is dimensional dysplasia? When the dimension of acetabulum is different, either it may be too small or too large. Like acetabulum is too small to cover the femoral head adequately. Like if you see this, that if the femoral head is in round shape and almost the 25% of the femoral head is not covered by the acetabulum, where the acetabulum is smaller compared to the normal femoral head. Or it can happen the acetabulum is too large and permitting the head to subluxate, and that is very commonly seen in case of the DDH, because if you see that the left side, the first figure, where the femoral head is normal but acetabulum is large, if it is not getting corrected in time, the femoral head can migrate laterally and can ultimately lead to the subluxation, and that is called as the dimensional dysplasia. That acetabulum, the size of the acetabulum is larger compared to the normal femoral head. And these are the types of dysplasia. Directional dysplasia, where the acetabular dysplasia, the inclination is more, the size is normal. Dimensional dysplasia, either the femoral head is normal, but the size of acetabulum is smaller or large. How can we correct? There is a management of the acetabular dysplasia. There are various osteotomy like Salter osteotomy, Pemberton osteotomy, Dega, Stihali, still triple osteotomy, Bernese osteotomy, or Chiari's osteotomy. And most of the times you will be confused when we'll get about the Salter, Pemberton, Dega, or the triple Bernese or Chiari. But I will make it very clear how can we get it a choice of the osteotomy. If there is a directional dysplasia, you can correct the direction by doing about reorienting or the redirection osteotomy. So what are the redirection? It's like the cap over the head is not oriented properly. We can correct the orientation of the cap over the femoral head. Is it similar concept? When the cap is not appropriately oriented, we can correct it the orientation of the direction of the acetabulum. So what are the redirectional osteotomy? The Salter, triple, and periacetabular osteotomy. What is the difference between Salter, triple, and periacetabular osteotomy? Salter osteotomy is a cutting in an innominate bone at one level. Double and triple means cutting about the pelvis at the 2 level or 3 level. 3 level means ilium, ischium, and pubis. And what is a periacetabular osteotomy? Rather than cutting fully the ilium, ischium, and pubis, we can do about incomplete osteotomy of the ilium and cut around the acetabulum. But all three are the reorientation osteotomy. Why it is all three different? Because the pubic symphysis will be working as the hinge, and it would not be appropriate to get it rotated acetabulum after the 8 years. So if you see about the child beyond the 8 year, the Salter osteotomy would not be useful, where the triple or periacetabular osteotomy would be needed. So if you read in books, there are the many osteotomy like the Salter osteotomy, periacetabular osteotomy. All the names are different, but either it will be single level cut, double level cut, triple level cut, or an incomplete cut. In other sense, we can say Salter, triple, or a Bernese, or the Gans, or the periacetabular osteotomy. So what are the principles? When there is the direction is abnormal, we can correct the direction, cutting about the femoral, the acetabulum about at the through and through, and that is a typical Salter osteotomy, and improve the coverage on anterolateral aspect of the femoral head get coverage. So this is the schematic presentation of the acetabular dysplasia corrected with the Salter osteotomy. And what is needed whenever it's a complete innominate osteotomy, it is always used to fix with the single or a double wire and a grafting. This is an example, acetabular dysplasia, where the head gets subluxated. It is treated with the above and below. Don't concentrate on below, but if you see, there is the anterolateral graft has been kept and fixed with a couple of wire and got the good concentric reduction. What is the principle of the triple osteotomy? As I said, beyond the 8 years of age and before triradiate get closed, we need to perform the correction, the reorientation of acetabulum by the triple osteotomy, cutting about the ilium, ischium, and pubis. So this is, and it has to fix with the one wire, but most of the time you need not require to keep any graft. And the third osteotomy is the Bernese osteotomy, recently developed by the Professor Gans, and we need to cut about its combination of the 5 osteotomy, the ischium, ilium, posterior column, and the most important is the posterior cut joining the both the second cut and the third cut. It's a little complicated. It's required to have a training, but it's only required to do this osteotomy only after triradiate get fused. Because if you try to correct with the Bernese or the periacetabular osteotomy in young child below 12 years and triradiate is open, you may injure, you may go and penetrate intraarticular or can do the early triradiate fusion in kids. So this osteotomy, periacetabular osteotomy, is required to do in adolescent or in adult to correct that directional dysplasia. Now coming to the second point, it's a dimensional dysplasia. As I said, dimensional dysplasia either it may be a smaller or a larger. First of all, when the acetabulum is large, we need to do the volume reducing. We need to reduce the volume of the acetabulum. And what are this osteotomy? If you see the volume is large, we can reduce the volume and keep about the graft, either the complete or an incomplete osteotomy. Incomplete osteotomy in terms of the Dega, complete osteotomy in terms of the Pemberton. So we can do about either the anterior coverage or a lateral coverage or the Albi's osteotomy, depends on that wherever the acetabular dysplasia is present. Whenever the acetabular dysplasia is more, it can be also corrected with the Pemberton osteotomy. So whenever large acetabulum with a normal femoral head, we can connect with the Dega or a Pemberton osteotomy, reduce the size of the acetabulum. Next topic, when the acetabulum is small, we need to augment, we need to increase the volume of the acetabulum, and that is the volume increasing osteotomy, either the self or a Chiari osteotomy. One of the important aspect is the self or Chiari osteotomy, but recently people have migrated from the Chiari osteotomy. The indication of the Chiari osteotomy, I'll come to that point, is only salvage osteotomy, where you can get about the non-congruent hip joint in case of the infection. It is a salvage osteotomy because its lateral coverage is only by the pelvis bone, and that is not covered with the hyaline cartilage. So it will cover with the fibrocartilage. So it would not be indicated whenever reorientation or the reshaping can be possible with the other osteotomy. So the small acetabulum with the normal femoral head, we can augment either with the self osteotomy or the Chiari osteotomy. So acetabulum is small and a normal femoral head, we can augment the acetabulum by the self osteotomy. There are different type of the self tectoplasty. I'm not going in detail about technical aspect. You can fix it or leave it, but we can improve or increase the volume by keeping the graft on an anterolateral aspect. Another aspect, whenever there is a dimension osteotomy with acetabulum is normal, but the femoral head is large, again, it can behave like a dimension osteotomy. We can do about the volume increasing by the self or Chiari. Like this, if you see the left side, the femoral is and acetabulum is equal size. If you see the middle figure, the femoral head is large, like a Perthes disease or the mild avascular necrosis. Normal acetabulum with large femoral head, you can cover with the doing about the self or the medial displacement Chiari osteotomy. This is one of the example that the self osteotomy, and as I said, the Chiari osteotomy, we can keep it for the aspherical incongruent where the other osteotomy is not possible. We can do about the Chiari osteotomy. This is one example. The left side hip is subluxated. It's almost right. It will get fused. The normal adolescent, it's not possible to get the moving about the acetabulum in such a huge direction. The child was treated with the Chiari osteotomy and the outcome was reasonable. This is another example, that this self osteotomy, and this is the improved the coverage by the lateral coverage. Acetabulum has been covered. We can combine the self and Chiari osteotomy like this. It's very common to have in a cerebral palsy in the adolescent where the hip is get dislocated. We can do the open reduction and can do the self and Chiari. This is another example of the self and Chiari for this. Don't go for the example. Understand about the principle of the osteotomy. When should we do? In short, whenever we can get the concentric reduction and less than 8 years of child, when it's a directional dysplasia is there, you can do about correction by the Salter osteotomy. When there is a dimensional dysplasia is there, we can do about the Pemberton or a Dega in less than 8-year-old child. When the child is older and there is a direction dysplasia, they can correct with either the double or a triple Sutherland or the Tonis osteotomy, that is a triple osteotomy. And when there is a dimensional dysplasia, again, you can do up to the 15 years of age, either the Pemberton or a Dega. And more than 15 years, the direction dysplasia, if it is possible to get the good and spherical congruent hip, we can do about the Bernese or a Gans osteotomy, but the prerequisite triradiate should be close. Whenever there is no concentric reduction, we can get the aspherical incongruent. You can think about the Chiari osteotomy or self osteotomy or combination, because these are all the salvage surgery. It's not getting concentric reduction. That hip may not last as that Salter or a Pemberton or a Dega osteotomy. Coming to the second other aspect of the hip joint on the femoral side, the femoral dysplasia. As I said, the femoral dysplasia can have the coxavara or coxavalga. So we need to understand why need to correct the coxavara. What are the problem with the coxavara? It can affect the final shape if it is happening in very young child. It can affect the final shape of acetabulum. It can lead to the alteration in hip mechanics, and very common to have unsightly Trenberg gait or a lurch and abductor weakness. It can lead to the progressive deformity of the hip joint if it is not corrected in childhood, or it can lead to the extra-articular impingement like abduction of the hip joint, range of motion would be affected, or the coxavara can lead to the secondary alignment, secondary malalignment like genovalgum with the knee joint. It can affect the secondary deformity of the knee joint. And the not least, it's an important aspect. If it is not treated in childhood and it can lead to the adult surgeon, it can lead to the varus displacement of the femoral stent if it is required to do the total hip replacement, if the hip can lead to the arthritis. Similarly, why need to correct the coxavalga? If it is the coxavalga, that can produce the maximum stress accord over the hip joint, and stress can lead to the early osteoarthritis, and that can lead to the osteoarthritis of hip joint, and some literature suggests osteoarthritis of the knee joint as well as. So the optimum position of the neck shaft angle would be required. It would not be too less like coxavara. It would not be too more like coxavalga. So what are the various osteotomy? Valgus osteotomy, varus osteotomy, trochanteric osteotomy, Mosker's osteotomy, osteochondroplasty, and reshaping. Mostly I will concentrate on valgus and varus osteotomy and few principles of the trochanteric osteotomy. Not going in advance of the osteochondroplasty and femoral head reshaping, but as I mentioned, because at the recent era in 2021, if you are appearing for the exam, you need to mention about the femoral head reshaping and osteochondroplasty whenever it will be asked about the femoral osteotomy. So this is an example, the child with the DDH, the treated with the hip spica, is presented with the coxavalga with the caput valgum. So what is required? We need to require the correction of the femoral, the side and the acetabular side. So if we wait about more, that can lead to the problem and the development of the femoral head. Generally, we can wait up to 2.5 years after the open reduction. We can enough time for acetabulum to remodel. It's not getting corrected. We can do about acetabulum femoral osteotomy if the coxavalga is there. So basic principle is there. Whenever there is a coxavalga, you can do about the varus osteotomy. If there is a excessive anteversion, we can do about the derotation osteotomy. If it is combination of coxavalga with the anteversion, we can combine the varus with the derotation, that is varus derotation osteotomy. Another principle for the Perthes disease, the Perthes is required to have the preventive surgery. Like if it is extrusion happens, then we need to correct the extrusion by the containing. We can do about the varus osteotomy. But the prerequisite for doing about the varus osteotomy in Perthes is to get the normal range of motion of the hip joint. I'm not going in detail, but the prerequisite, I'm not going in indication when to do about the video, but whenever we want to do containment with varus derotation osteotomy, the prerequisite would be normal abduction. The question is why? If we are not getting about preoperative 25 to 30 degree abduction, if we do about the varus osteotomy, the hip will permanently go in adduction deformity, and that can lead to the subluxation. So the most important to have the gaining normal range of motion before doing varus. Similarly, if we need to get the internal rotation, if we need to do about derotation osteotomy. So this is example doing the varus osteotomy, and the child has been followed, and till the maturity, it is having good and spherical hip joint. That is the goal of doing about the femoral osteotomy for varus derotation. The basic principle for the other osteotomy, like the greater trochanteric overgrowth, like this child has got the greater trochanteric overgrowth. It is very common following the growth arrest, either following the avascular necrosis or a Perthes disease, where the greater trochanter would be growing normally compared to the proximal femoral growth plate. How can we correct? We can correct by the three different methods, either doing about the trochanter transfer, either doing about relative neck lengthening, or either we can do about the true neck lengthening. So in other sense, when we see this side of the case, the neck is short, that is a coxa brava would be there. We need to correct, we can correct by the three different methods. So this is number one method, the old standard, and where we can take about the trochanter and transfer it distally and laterally. Important aspect, distally and laterally, where we need not to remove the middle part of the impinging the trochanter or the normal trochanter. That's a trochanteric transfer. So what is the relative neck lengthening? We can do about the cut, take it similar to the trochanter transfer, but middle part we take off, we remove the middle part and transfer it and get about the relatively neck lengthen. We transfer laterally again and distally, but the neck would be removed, so it would not cause any impingement in abduction. That is a relative neck lengthening. And what is a true lengthening? That we take out the trochanter, and that would be combination of the original trochanter transfer is a single osteotomy. What is a relative neck osteotomy? That is a double osteotomy. We'll take out the flare of trochanter, we'll take out at the superior border of the neck, and true lengthening we need to do about the inferior aspect of the femoral, the neck. There are the triple osteotomy, and what we do about that, we do lateralize the shaft and fix it with the trochanter will fix it and fix it with the side plate, because that is required to get the length of that. Now question comes, what should we do and when should we do? These are the requirement. It will correct the mechanics, but it is more complicated, and it may indicated whenever you need to correct the length. Whenever you need to correct only about trochanter transfer, it would be safe to do that relative neck lengthening. We can see about the vessels, where is the vessels, and that's how you can differentiate between correction about the trochanter transfer. This is an example with the same patient with the trochanter advancement, the simple trochanter advancement fixed with the 3 screw. This is the coxa brava, that is called as Moscow's osteotomy. It's actually done with the true neck lengthening, bits divide about the 3 osteotomy. You can see the 1, 2nd part and 3rd part, and keep the graft, and the entire shaft has been lateralized and neck shaft angle has been restored. And this is the example where the trochanter overgrowth is there and treated with the neck lengthening, where we can transfer about the trochanter part above the superior aspect of the neck has been removed and corrected with the 2 screws for the trochanteric transfer. The last but not least, we need to talk on the displacement osteotomy. And what is the displacement osteotomy? Whenever the forces across the hip joint would be less, most of the time it has not been indicated, because it can lead to the secondary degenerative or secondary forces at the knee joint. But for the exam going student, we need to say that it's a McMurray's osteotomy. This is a child presented with a 3 failure of the surgery, treated with the medial displacement. When you do about the medial displacement, typical example for the neck femur osteotomy. Nowadays, not many people will do that, but this is for the completion we need to do about the McMurray's osteotomy. That is a medial displacement, armchair effect of the McMurray's osteotomy. We can combine the osteotomy like this, combination of the acetabular and femur, when there is a anteversion acetabular dysplasia along with the coxa valga. We can correct the coxa valga with the varus. We can correct the anteversion with the derotation, and correct about the acetabular dysplasia with the reorienting osteotomy. So this is another case where we can do about the prerequisite. We can plan that whether it is getting congruent on abduction and interrotation view, and it's getting it better, we can do about the varus derotation osteotomy. And acetabulum is not getting corrected, we can do about the acetabuloplasty. The message I want to give, what are the variables we need to correct before the correction? This is the age of the child, if it's very young, or remodeling potential is left or not left. Etiology depends on the various etiology, whether it's osteopenia is present or not. What are the functional disability and long-term effect, whether it is static or progressive problem. The quality of bone, whether it's a good or a poor. Then we need to focus on whether the physis is normal, inclination is normal of the proximal femur and trochanter. The acetabular dysplasia is how much, the joint orientation is how much, severity of deformity is more, whether it's a unilateral case or a bilateral case, and we need to check about the limb length discrepancy. Why I kept it? Because we need to check these are the informations are needed in the clinical examination for every single case before deciding for the osteotomy. In generally, for deciding factor for the osteotomy, for the acetabulum, whether it's a directional dysplasia or a dimensional dysplasia, the acetabulum is small or large, whether we are getting congruent hip joint or not. If it is congruent hip joint, it is always desirable to do the osteotomy of the proximal femur and acetabulum. The age of the child, as I said, less than 8 years, the Salter can be done. More than 8 years, triple osteotomy would be required. More than 15 years with triradiate fuse, we can do about the Gaines osteotomy. The most important aspect of the experience of the surgeon. Surgeon must be aware about what he's doing and why he would be doing. That is also needed. In other sense, the child's, the hip is different than adult. The etiology is of the hip joint is very important for the doing and selecting the osteotomy. An analysis of the acetabulum and the proximal femur is very important to plan about the osteotomy. The timing intervention is very crucial when you are going to do the osteotomy. And the most important aspect of the children orthopedic, every single child must be followed till the adult to know actual effect of the osteotomy to preventing the osteoarthritis of the hip joint. Thank you. Any question?
Thanks, Hitesh. That was absolutely fantastic, because you've covered almost the entire gamut of osteotomies in the short space of time. It's and clarified the principles so that most people would understand it. Thanks a lot. That was great. I think there must be some questions. So let's first go over to the, there's one question from in the chat box asking from, apart from plasticity of superior acetabular margin, is there any role of open triradiate cartilage in Dega osteotomy?
Yes, the open acetabular triradiate would be required because the Dega osteotomy will hinge at the triradiate. So the triradiate should be open before selecting about the osteotomy in the Dega osteotomy. So it must be needed. That's why I said less than 15 years, the osteotomies would be directional is Salter. If it is a dimensional dysplasia, Dega or Pemberton.
Thank you, sir. Usually in exam, even for the recent OSCE, they used to ask Salter osteotomy many a time. So can you please in little detail about the Salter, sir?
Yeah, the Salter osteotomy, actually it was very popular before the Pemberton and Dega has come. The many of the surgeons have moved from the Salter osteotomy because if we want to correct more than 15 degree of the acetabular dysplasia, we cannot get it from the Salter osteotomy. So if you want to know about the Salter osteotomy, it's a complete innominate osteotomy. What do you mean by complete innominate osteotomy? It will cut from the anterior to posterior. So if we know about the indication, we need to do the osteotomy when there is a pure directional dysplasia in a child less than 8 years. So we can move about the acetabular in a better position. So number one, we can get about the good congruent hip joint. The Salter osteotomy is not indicated when hip is not located. Yes, that's a very important question. I will emphasize again. The Salter osteotomy is to correct the acetabular dysplasia. Salter osteotomy is not replacing the reduction of the hip joint. So if the postgraduate be asked in exam as the DDH case, you should not jump first to the Salter osteotomy. First, to get the reduction of the hip joint is a priority. Then congruency, and third, when the correction of the acetabular dysplasia to maintain the stability. Now, coming back to the Salter osteotomy, how to do that osteotomy? Less than 8 years, the acetabular dysplasia, it's not reoriented properly. We can correct about acetabular dysplasia by cutting about anterior to posterior, complete the ilium bone just above the acetabulum, between the just above the inferior pubic rama, the anterior inferior iliac spine, and correct with the keeping the graft on the anterolateral aspect. If you do about Salter osteotomy, you keep in a figure of 4, then anteriorly part would be open, and we can take out the graft from the either the allograft or the autograft, take out from the ilium, keep it on the base on the anterolateral aspect, and fix it with the wire, couple of wire, and always protect with the spica. The benefit of the osteotomy is quite simple because we need to cut from the anterior to posterior. But the disadvantage of the Salter osteotomy, if it has been, it's unstable, inherently unstable. We have to fix with the wire, and whenever we'll fix it with wire, we have to remove the wire.
We have to keep it in a cast as well.
Yes, we have to keep it in cast as well. Yes, spica is needed.
Yeah, I think, and the other problem is that it only increases anterolateral coverage. If the problem is more posterior, then you can't use a Salter osteotomy to help you with that. So
yes, in fact, as you mentioned, is very well. In neuromuscular cases, the Salter osteotomy is not indicated. It's contraindicated because it will produce the retroversion. There are the articles on either side, the acetabular side and this side, both side would be there, but the neuromuscular disorder, the reoriented osteotomy is usually not required, not indicated.
And so in those cases, sir, where there is posterior wall is deficient, which one you used to prefer?
We can do about the San Diego osteotomy or that's Dega, both.
So Dega modification, San Diego modification of the Dega osteotomy, basically. So you can cut along the acetabular margin almost circumferentially, posteriorly, and then you hinge it and then put in graft to hold it there. Yeah. And in fact, if you can get it right and nicely jammed, you don't even need a cast for the osteotomy. You may need it for your hip dislocation if you're doing it at the same time, but you don't need it to hold the osteotomy because the graft gets jammed in nicely.
And so you have mentioned in your lecture that Dega is incomplete osteotomy. So what is incomplete?
It's like the incomplete osteotomy is the Salter we have to cut from the anterior to posterior. So we are cutting the complete ilium completely. If you see the ilium, it goes from the anterior to posterior, it's completely, where Dega is keeping it hinge intact. That's why it will call as the incomplete osteotomy. It will cut it the anterior and anterior part also, but it's not only lateral, it cuts the anterior half also, but it will hinge. So when it's hinged, it's inherently stable.
Yeah. So you're not cutting all the way through from anterior to posterior as you do in a Salter's osteotomy. Salter's osteotomy, you're cutting all the way from just below the anterior inferior spine to the sciatic notch. Okay.
And so when you mentioned about the age, sir, less than 8 years, that means that triradiate cartilage should be open in that case.
Yes, yes.
And so what is the ideal position to put a spica cast after the osteotomy? Yeah.
After the osteotomy, we can keep the spica in, depends on what we are doing. If you are doing of the DDS, the ideal position of the spica is not more than the 35-40 degree of abduction. It is in the 15-20 degree of flexion. Depends on that. That would be the ideal position to do about immobilization.
And so, in few cases, I have seen sir is doing shortening also. So, in what all cases it is needed, sir? Shortening of the femur with osteotomy.
Yeah, in case of the DDH is older than 2 years, where the head is migrated proximally, where we need to bring down the femoral head. And second time, even though it comes down at the level of the acetabulum, we need to prevent the secondary avascular necrosis. We need to do shortening. Second, if we reduce it and check about range of motion, where the range of motion is restricted, I will do about the shortening. I don't hesitate even in younger child with the teratological or the syndromic the hip dislocation. Generally, it will by and large in a DDH case, 2.5 year, it may not require 2.5, but it's not hard and fast rule. Depends on the laxity. If the child has got laxity, the shortening may not be required, but child doesn't have laxity and syndromic, child may require the shortening early.
And so, in case of varus derotation osteotomy, how to decide about the varus? Because as you mentioned in your lecture, that with the age, the orientation also change, like version and all. So, how to decide about that?
Yeah, the most important part for the varus osteotomy is there. We need to be optimum. It should not be more and it should not be less. So what is more? Because if it is going beyond the 110 degree, it is more. The neck shaft angle is going below less than 110 degree, it is more. What is less? Less than 20 degree, or if it is not achieving the goal, that is less. So in other sense, we need to decide the take child without anesthesia. We take the child in abduction view and see about the congruency of hip joint. Whenever we get the good congruent hip joint, we need to do about the varus osteotomy. So if you see in a Perthes, the 20 degree of varus is enough. But if you see in case of the cerebral palsy, in the GMFCS 1, 2, and 3, it depends on how much we are getting about congruence. But if we are getting GMFCS 4 and 5, the varus is required more, because in either way, child is not going to walk. So the varus will be required more.
Yeah, and they also have quite a significant coxa valga.
Yes.
Unlike in a Perthes.
Yeah, so it's not the always fix that we need to do about 20. So that is the reason I never mentioned degree of the varus. Depends on the age, etiology, and as well as the congruency. The hip is congruent, that much varus is required.
So there was one thing about Perthes is between a varus derotation osteotomy and a varus extension osteotomy.
Yes.
So there's some people who say that you should not do derotation. You should do a varus extension. And so, what is your take on that?
Yeah, we do actually and whenever the Perthes child comes, we always keep the range of motion improvement by the above knee skin traction, and we assess that after 4 to 5 days. And once the range of motion is normal, we can do about the 20 degree varus and 20 degree external rotation. But if we are not getting the internal rotation, we never derotate in externally, we do the in extension osteotomy. So that is also serving the same purpose. So if we do about varus derotation or varus extension, it will contain the hip joint. And the most of the Western world, we do only isolated varus osteotomy. So the Perthes, the concept is varus or varus derotation or varus extension. All three would be correct.
Yeah, and I think it's a good idea to check what position the head is best contained in.
Yes.
And osteotomy accordingly.
Yeah, so I always take the child under anesthesia, and I always check every osteotomy. I always see myself and check under image, and which is the best position, and decide. That is the most important deciding factor for the doing about osteotomy.
Agreed. Great.
So, there are few terms which is when I was PG, it is difficult to understand, like about the congruency, containment. Containment I used to read during the Perthes disease only, I think. So in these terms, can you just elaborate on these ones? A few terms, what is usually asked in the
So,
exam? Easy to know.
Congruency means that the acetabulum and femoral is forming in a same shape. Like if it is round, that is also round. If this is flat, that is also flat. So that is called as congruency. What is called as containment means reposition of the femoral head inside the acetabulum. Repositioning of the femoral head inside. The containment word is useful only for this disease because the femoral head migrates. So for postgraduate, important is that femoral migration, femoral head exclusion, and femoral head subluxation. All three are same. When femoral head is going out of the acetabulum, in the DDH, it is called as subluxation. In Perthes, it is called as the extrusion. In CP, it is called as migration. But all are same. Like you are taking it lateral margin of the acetabulum and how much it is getting out. Similarly, when you are doing the surgery, in Perthes, it is called as the containment. In case of the DDH, it is called as relocation. And in case of the CP, it is called as reduction. So that is the reason many times the people will get confused.
And so, sir, one thing about the FAI, sir. So in these diseases, what we have is femoroacetabular impingement. It is always in all these diseases, or is it something different?
No, FAI is different. Yeah.
The
You can
FAI,
have it, but it's a different concept altogether.
Can you please elaborate on that one also?
the FAI is that is the reason I have actually not included, because you initially asked
It's a
about
completely
the
different.
DDH.
Yeah.
So I said only on the acetabular dysplasia, on the femoral dysplasia. The FAI is a concept of the femoral head impingement. Either it may be related to the abnormal shape of the femoral head or the
acetabulum.
Yeah, so either it's a calm impingement or a pincer impingement. In broad sense, when the femoral head shape is normal, then it can lead to the calm impingement. And when there is the acetabulum is abnormal, that is called as a pincer impingement. But that may be the combination of both.
So this is not a problem of subluxation or dislocation.
Yes.
It is in joint, but in some movements of the hip, the head is hitting the labrum and gradually damages the labrum. And this is what Gans is sort of described as his theory for development of what was known as primary osteoarthritis. So early on, we used to talk about primary osteoarthritis of the hip joint. Now the concept is changing that most of these have some previous element of impingement, tabular cartilage, and then leads to osteoarthritis. Okay.
One more term which is usually asked is acetabuloplasty. So what is that one, sir?
Many people will use the acetabuloplasty for the dimensional dysplasia. Whenever you do the Dega or a Pemberton, then use as a acetabuloplasty. Acetabuloplasty is nothing as the reconstruction of acetabulum. So when you are orienting, we are changing the
shape of the acetabulum.
Shape of the acetabulum, that is called as acetabuloplasty.
And one more is augmentation osteotomy. What is what?
Yeah, that is a volume increasing osteotomy. The augmentation means increasing. When we increase the volume, that is augmenting osteotomy. That is self osteotomy.
So, okay, self osteotomy. And
Chiari.
In a way is an augmentation, or the tectoplasties which the Japanese like to do.
Yeah, there are different types of that's why I said I am not going in detail of the self osteotomy. People with wire, people may use with screw, may use about the plates. So the postgraduate can concentrate only on principles. That is not on technique.
Yeah, I think that was actually very sort of enlightening and was a very excellent explanation of the various principles. So I think people should have clarified a lot of the doubts that they had before this. Thanks a lot. Thanks very much, Hitesh. It's always a pleasure to have you with us. And I think we are coming to 7 o'clock almost, or 8 o'clock. So maybe we should call it a day. Is there any other burning questions from the PNB students? Because
So I think,
they all.
yeah.
So we'll ask them questions tomorrow on this talk because they don't have any questions.
Yes,
Okay,
sir.
great. Thanks a lot, Hitesh, and thanks everyone.
Okay. Nice to see you. Thanks.
Great.
Thank you so much, sir.
Good night. Good night.
Thank you, sir.
Thank you.
Thanks.
Thank you so much, sir.